Good morning. Thank you so much for being here this morning. My name is Elizabeth Avila. I am a professor in the Department of Population Health, and I am very, very excited to be able to introduce to you our speaker for this afternoon, or morning and afternoon. We have a little bit of a background to this that I just want to sort of set the stage for you before I introduce Dr. Kane. The first is that we had someone named Chad Harmon, who is the executive director at Substance Abuse Center of Kansas. He presented a couple of months ago, and he talked a little bit about some things, including briefly that brief intervention as part of the SBIRT, or screening, brief intervention, referral, and treatment. And so Dr. Byerly in particular was very interested in us exploring that brief intervention a little bit more, digging into motivational interviewing. So this was really a great opportunity for us to follow up. So we're thinking about the SBIRT model, that not everyone is going to be doing all sorts of deep interventions with folks, but maybe this is an opportunity to do a brief intervention. So we are very excited to have Dr. Kane here, and she will be able to talk a little bit about motivational interviewing and give you some examples. So Dr. Mary Kane is an education associate professor at the University of Kansas School of Medicine in Wichita, where she works with simulation, interprofessional education, collaborative care, and faculty development. Previously, she served in both faculty and administrative roles for 26 years at Wichita State University in the College of Health Professions. Dr. Kane's formal education includes a diploma in nursing from Bethel Deaconess Hospital School of Nursing, a Bachelor of Science and a Master of Science in Nursing, both from Wichita State, and PhD in nursing from the University of Kansas. Rock chalk. She has completed courses in leadership development and coaching at Kansas Leadership Center just down the road, along with completing the Harvard Kennedy School of Executive Leadership program, which is called the Art and Practice of Leadership Development, which is a really great opportunity. She is a certified healthcare simulation educator, and has presented and facilitated simulation workshops nationally and internationally. She balances her passion for interprofessional healthcare education, simulation, and collaborative care with an equally active family life that includes her husband, 2 married children, and 6 grandchildren. Please help me welcome Dr. Mary Kane.
Thank you very much. Actually, your food smells really good. Go keep eating. It sounds good. Now let's see if I can get everything to work like it's supposed to. That first slide you needed because you had to have it on here. I added this one in just because I'm going to talk about motivational interviewing, the art and science, because it's both. But I really think it's about having a good conversation about behavior change is what motivational interviewing is. I'm starting with this, and if you've been in our simulation center, you will see this on the wall, but it's something we truly believe in up there. I believe in this, and so I think it's important to put that out to everybody that's learning today, because we believe truly that everyone participating is intelligent, capable. You wouldn't be here in these seats if you weren't. You care about doing your best, and the whole point of being here is just to improve what it is we do. That actually comes from Harvard Sim Center, but they say anybody can use that, and so we do. So today, just to have the educator and me, we have to have objectives, is we're going to talk a little bit about the theory and some of the evidence that goes along with motivational interviewing. I'm going to look at some of the strategies that go with it, and also then we're going to let you do a little critique of a motivational interviewing. Dr. Abla and I are going to do a little role play for you. So with that, just to let you know that motivational interviewing came about by a person by the name of Miller and Rolnick really are the authors, if you will, of motivational interviewing, but back in the 1980s. And it started with the treatment of working with patients with alcoholism. And so this is their first definition, that it's client-centered counseling style for eliciting behavior change by helping clients to explore and resolve ambivalence. And you're going to see that word ambivalence throughout this presentation this morning, because there's a lot of really what motivational interviewing works with, I think, is that ambivalence that's there, that with patients. They also say, this is Miller and Rolnick, that no person is completely unmotivated. And you may or may not agree with that, but that's their belief. And so um, I kind of go with that too. Years ago, a friend and colleague of mine, she's a nurse. She was when I first knew her, she was a school nurse. But as we were having a conversation one day, because sometimes I would sub for her, but she said, I used to work in a nursing home, and she said I was the director. And she said, I decided I would call families. Said I wasn't going to just call them when there was something wrong or the patient fell or something. So she said, I just made the assumption that they cared and that they wanted to hear. And that really struck me. So that's kind of stayed with me. And I've kind of adopted over time the attitude. I try to see things as patients want to be healthy. Whether they are or not at the time, they want to be healthy. There's just things that get in the way. So I kind of think that's where they're coming from, that nobody is really unmotivated. It's just have to help them. This is another definition, and I like it. This Berger and Williams actually wrote a book on motivational interviewing just for healthcare professionals. It's a great little book. It's a paperback. It's a good one. But they say it's through the synergy that occurs when rapport with the patient is used to lovingly address the doubts, worries, concerns, issues arising within the patient. Sometimes it's described as the spirit of motivational interviewing. And kind of the four pieces here are partnership, that you're forming a partnership with those patients and families, accepting them for where they are, compassion, and that evocation, or you're trying to really evoke those motivations in them and get them channeled in the right direction. Another one says adopting the right heart set. And I really like this one because I think that's what it is. It's more than the words, it's about adopting the right heart set. And you will see it's kind of the same four things again. Here's what it's not. It's not considered an intervention in itself, although I'm going to talk about some studies that were done, the research behind it, and they do treat those as interventions. But I don't know, everything you read says, no, it's really not. It's not something you do to the client or the families. It's something, it is not something you do instead of what you already do. It is not a theory. It's based on theory, some theories, not really, but it's also not a cure-all. So context is very important as to what we're talking about. So if you're talking about substance use disorders, we know there's biological, psychological, and social factors. So motivational interviewing is not the cure-all for all of that. Some more things if want to help think, oh, okay, so what is it? This is Miller and Rolnick, and they come up with this acronym of RULE. It's about when you're speaking with patients and working with them, they use this, and it's resisting the writing reflex. We're health professionals and we want to fix people. We want to treat them. Not everybody's ready to be fixed. And so we have to resist that writing reflex. We have to learn what their motivations are, what does motivate them so that we can use those and get them channeled in the right direction. Listening is very important. In fact, probably more important that they talk more than we do. And empowering, although you will find that some will say, no, it's not our job to empower. They're already empowered. They manage what they do. We'll talk about that later. So here's another one, some more principles. You'll see some of the same things. Again, it just kind of depends on who's giving the definitions, but empathy is usually there. This discrepancy piece is that ambivalence that's there, which I know you've all seen that in patients that I know I should do this, but there's always that but. I can't because, and we're going to talk about that. Fostering their beliefs and change, kind of see where they are and looking at that. So their motivations. So that takes a lot of reflective listening, reflecting things back to them, open-ended questions, a lot of affirmation. This is also another acronym that you see associated with motivational interviewing, and you'll see it's kind of the same, open-ended questions, affirmations, reflections, and summaries. So theoretically, I said there wasn't a real theory, there isn't. And, Miller and Rolnick will tell you this, that there isn't a specific theory, but as you look at it, there's a lot of background and a lot of theories that help explain it. And the one that you will see the most is this trans-theoretical model of change. You probably can't read about motivational interviewing without reading about the trans-theoretical model of change. So I am going to talk about it just a little bit. And the reason I'm going to talk about that is because I want to know, how does theory help us? I I used to teach nursing. I taught it for a very long time. And for a period of time, I taught second semester nursing students and I taught research. And now, if you know anything about where you are, and when students are first learning, I can tell you research is not at the top of their heads, right? You want to do things. And so, a second semester nursing student, they'd had a good day if they got to give an injection to somebody. That was a great day. So I thought, well, how do I even talk to them about theory? So I kind of started out this way in the sense of if I drew a little circle, on the wall, that would be how much I actually know or we actually know. And there's all this out there that we don't know. And theory just helps us organize all that stuff that's out there that we don't know. And we all theorize all the time. So when it comes to working with patients with any kind of substance use disorder, there's stigma, there's bias, there's stereotyping. We may not even realize we're doing it, but we do. We do. When they show up in the emergency department, how many times you kind of get some little names you attach with them? You know they're there. You've seen them before. They're there again. But that can create some stigma and bias. So there's studies about that out there and even healthcare related stigma that sometimes keeps people from getting the treatment and the care that they actually need. So I am going to talk about theory. This one is this trans-theoretical approach. I'm going to click through this quickly because I'm going to actually talk about each one in the stages. The reason this one is helpful and why theory is helpful to me, it helps with my mindset. How am I going to approach people? And I can just approach them with my own ideas about why they're there. But if I got to clear my mind and think about, oh, wait a minute, there's reasons that things are going on. So this theory is one that's extremely helpful. In this theory, you're going to encounter people who are not ready to make a change. They're resistant, in fact. I know you've met them. So one time I was doing this at I don't know, don't remember exactly where it was, but it was about the whole thing with the conference was about smoking cessation. But I was talking about this theory, and down here in front, somebody raised their hand and said, "Hey, that's me. That was me." And he said, I'm a respiratory therapist, and I used to smoke. And he said, at that time, if somebody told me I needed to quit or I should quit, he said, that just made me dig in my heels and want to make smoke that much more. So I thanked him for his testimony for the day. I said, you're supporting a theory along the way. But it's there and you pay attention and sometimes it's like, man, why don't they get it? They just, if you just quit, whatever you're doing here, it would really help. Unfortunately, that doesn't necessarily always help. And the more we go after them, the worse it gets. And you may never won't see them again, maybe not for a long time. But the language that's good in here is when you use the I am concerned about. And you say that I'm concerned about, and you connect it with something else that's relevant to them. I'm concerned about your drug use and your relationship with your children, or something that would connect with them. And then you kind of have to maybe just leave it alone, let it sink in. So that's that stage. The second stage of all of this, according to this theory, is they intend to take action. And this is where you get those people with all this ambivalence. And this is where motivational interviewing can really come in, be really helpful. Because these are the people that will say, well, yeah, I know I need to quit. I know I need to change. It's really too hard. Or I know I need to quit, but there's always something out here. The pain is too great. So they will go back and forth and they can be there for a long time. But you don't want to lose those people. And that's why motivational interviewing can really help you with ways because you start exploring things with them, is what's going on. The third stage in this theory is prep. Yep, they're really going to do it. This is great. So once you got them there, definitely go with them. You make the plan, get them started, keep in touch with them, keep them going, start looking at triggers that might make them stop and, go back to where they were. And then there's the action where they actually are making that change. And, by the way, you got to look at those triggers and you do know that people always fall back. That happens a lot and they'll fall back to where they were. But you don't want to use those times that they fall back and restart whatever it is they're doing. Take advantage of that. Use it for, well, okay, so what did work? Even though if it wasn't too long a period of time, but maybe there's something in there that's helpful. So that's what you do in action maintenance. Yeah, they've actually got there and they're doing really well. But you want to stay there with them. Look, be concerned about relapse. You're still there. And the last stage is termination. And for most part, this says this doesn't really happen. I had to think about my dad. So I'll tell you a quick dad story. He was a smoker and only I don't remember him smoking. What I remember as a little girl, this was before you would have had the medications that we have and all this stuff to help with that. But he carried lifesavers in his pocket. So yeah, that's what I was interested in. So I don't remember him actually smoking. But over the time when he was in his 80s, and I don't remember how we got to the conversation, but he said, sometimes I still just want a cigarette. Although he never did pick up pick it up again. So I don't know if they ever really terminate. It just kind of took me by surprise because I thought all those years I've never seen you smoke or talk about it. It was interesting. One other theory that I just happen to like, but I think it's also has helped me with my mindset is theory of planned behavior. And essentially this theory says there's three components. There's behavioral beliefs, normative beliefs, and control beliefs. And those will all impact the intention to make a change. And the higher that intention is, the more likely we will to be to make that behavior. So when I'm thinking about people and talking with people, it's like, okay, so, what are their attitudes, whatever it is? So clinically, I'm primarily a maternal child nurse, but back sometime or rather, I did spend about 4 years working in surgical intensive care. And one day, my patient actually had come from coronary care. She'd come in with chest pain, but they were full. And so they sent her to us. Well, as it turned out, she did not have an MI. What she had was a very acute pneumonia. And that's where her pain was coming from because it hurt to breathe. And I remember standing there with her doctor, and he was telling her, you need to quit smoking. And she looked at him and she said, I've smoked for 50 years and nothing's happened yet. And I thought, oh, yeah, we're not going to get too far with this one, at least at this point in time. But attitudes are important. Like, where does this come from and what's going to be the resistance factors that you're going to meet? Normative beliefs. Now, this one in this theory, there's less evidence to support this particular concept, but I think it's important to look at it because it looks at just what's their normal life. A friend of mine who is a teacher in I'll just say quite large school, a high school. And she was telling me the story a year or so ago about how she said, part of my job, she says, other than teaching, she says, I have to monitor this hallway and this bathroom down here. And one day she was doing her job and she found a young man who was unconscious and he had OD'd. And they got him help and he's turned out okay. But she said what struck her was that his friends and other students. She said one of them said to her, said, just kind of shrugged his shoulders and said, oh, my mom OD'd 2 weeks ago. And that was just his norm. So I think that's really important to think about, where do they come from? What's their lives like? And what's normal to them, to people? And the third piece of this is control beliefs. Do they internally feel they have the ability to change something, or is it external? Yeah, I really think I know I can do this. I'm going to do this. Or is it, well, my I would stop and I would do something different if my boyfriend would, but I can't because he doesn't. So you got to look what's external and what's internal. And so that's what this theory, and that has just helped me a lot, really think about when I approach people, there's all this stuff in their life that I need to learn about before I can really provide some guidance and helpful with them. Because there's a lot of things you're going to have to work through to get through there. So I did label this the art and the science. So I'm going to give you a little bit of the science that's there. There's been a lot of research done on motivational interviewing. I think one thing I read said there's been over 1,000 studies done on motivational interviewing. And I believe it because when you search a little bit, just lots comes up. So I thought, I'll read some of the systematic reviews of these. And just to see what this one actually comes I wanted to kind of go over a little time span here. So this was a 2013. It was a systematic review. And they used 48 studies out of this. Now, what's interesting, if you look at the outcome measures there in the middle of this slide, they looked at a variety of things. That's what these studies brought in. And that's how a lot of motivational interviewing studies are done. There's quite a bit out there on substance abuse. That's where it kind of started, especially with alcoholism, but it's expanded. And so you'll see it in a variety of things. It didn't really find statistically significant evidence. This again was 2013 for some of these things. But they decided that there was clinical significance to this because overall there were some very beneficial effects of using motivational interviewing. And they found that at least 1.5 times more likely to improve over the control group. So very clinically significant, but not statistically. This one is another one from 2014. And I also looked at it because it was particularly related to substance abuse related outcomes. This one found that, again, that their conclusion was that motivational interviewing has been found to be effective in as little as just even 15 to 20-minute session with a patient, and how you work with them can make a difference along the way. Another systematic review says, I put this one here because I like their conclusion. If I go back to that heart set and the spirit of motivational interviewing, they didn't really couldn't figure it out. They were looking at what is it, the mechanized underlying mechanism. They can't quite identify it, but their conclusion was the way you are with patients is more important than what you say. And that's where I will come from with motivational interviewing. This was a Cochrane review, and it's on smoking cessation, but this one, I just to put one in that they didn't find really good. The low quality evidence is what they found on this one because the design of studies, and that's the reason I put this in there. It's really hard to measure motivational interviewing. You don't know how people are taught. There isn't a real direct way to do it. And so it makes it hard when you're going to study it. That how do you really design this study? That is one of the big problems with it. Now, I put this one in because it was just a little different. It's a newer study, but they tried group motivational interviewing. And I don't know exactly how they did it, but I thought that's different because just about all of them have been on individuals. So they wanted to try it with groups. And the result of this one was they did find some significant difference in some of the different areas over the treatment control group. And the treatment control group was the usual of education type things, making a plan and moving forward. So that's what they found. So they did see that drug use delay days declined with each follow-up, but ultimately there was no difference between them. And their conclusion was that it helped most at the beginning, at the entry, as to where they were using it. So that was this group motivational interviewing idea. How do the future studies, how's it work? We don't really know that for sure. And let's see. Oh, it stopped working. There we go. The last one I put up was a qualitative metasynthesis. Now, when it comes down to it, I love qualitative research. I can do them both, but this is kind of where my heart is. And I thought, well, we need to balance this out a little bit. So this one was about the lived experience of people with opioid use disorders, but those who are receiving medications to help with that disorder. So they particularly, when you do a metasynthesis in qualitative, what you're trying to do is pull together those studies and see if you can come up with any new interpretations of it by pulling them all together. So the three themes they came up with, and the one that seemed to be the strongest, was one about how person experiences the medication use. If you're one of these people, what's it like to live with it? And there was 8 sub themes. I didn't put them all up there, but they were all very similar. It was the type of thing of, in one way, by taking this medication, it helps my life be more normal. But on the other hand, I got to go to that clinic every week and pick it up and people see me. So there were these kinds of things that went on. So back to that ambivalence again. They also talked about the structure of the treatment and the ways that you do it all really had multiple, really affected how things went. And the third theme was that it was a stepping stone, taking the medication, that they hoped it was just one piece. I will get farther along. So from that, they came up with a new their conclusions was this new treatment approach. And you got to hear their lived experience, how important that is to listen to them. Low barriers approach, and what that meant was anything you can do to help access. So telehealth, whatever might work just to get the access better. And the third thing was to use motivational interviewing, because that helped get those personal narratives that you wanted to really hear from people. So I said the word ambivalence. So change is hard. It's really hard. But so much of it, according to Miller and Rolnick, is this ambivalence. They want the change, but they don't want the change. They want this side, but this is not incompatible with it. So that's what's hard. So talking about ambivalence a little more, if you think they don't have motivation, well, it's probably because they're being very ambivalent. If you argue for one side, the person will take up the other side. But then I have a lot of pain if I don't take the drugs. There's something there all the time. And the more they defend the status quo, the likelihood of them changing really decreases over time. So that risking this urge is like to take up the good side. You got to stay with it. But you also don't want to go with you absolutely must change. You need to change. You should change. That's not going to help people whatsoever. But you do want to verbalizing with them. So what we're going to do here to get us started to some of these words, you may talk to somebody next to you is just fine to do this. And we're going to take about 2 minutes. I put these words in alphabetical order, but I want you to reorder them. And top of the list will be, if you were using these words to start your question, what would be the most powerful word to use? Which one? And go down in order. So take just a couple minutes. And Elizabeth, I'm going to need you. Oh, you got it. All right. We're going to go around in just a little bit and just think about which words you would say, which, if you're going to ask this question, which of these words you're going to get the most bang for your buck, if you want to put it that way. So I'll give you just a couple minutes to do that. And if you're online listening, do the same thing. And give some thought. There is no right or wrong, but we want to talk about them just a little bit. Couple minutes, do it. Okay. Dr. Abelaz over here, she's got a microphone. Somebody say, well, how did you order your words? I'm just curious. Ooh, if not, we'll just put it in front of your face and somebody has to talk, There we go. Courtney will do it. Okay. You probably know what this is gonna
So we started with Y as our first because it really ends up.
Is the mic on?
Do I just need a whole
Now you're
closer?
better. Okay.
So we put Y first, because it just allows for like more of that like open-ended communication. It allows them to really speak what they're, really feeling and be able to actually tell you what they're experiencing. Next, I think we were kind of going with how, for similar reasons. We just felt like Y was maybe just a little better.
Okay.
Then third, we put what, and then last we did do. We felt
Okay.
that those two were more of like close-ended, more yes or no, simple answer questions. Obviously, there's just depends on what you're asking, but that's kind of the reason why we went in that order.
Okay. All right. Hang on to that. I want to hear from somebody else. Whoop.
That was not good.
Oh.
Nope, you were being.
Got some ideas. Yeah. Like I say, there's no right or wrong, so it's okay. Yeah.
Yeah, I think we went with how first, because again, it will allow you to kind of like allow them to dive in deeper into the question and think, maybe like, how do you think that's affecting your relationship? So I don't know, it's not a yes or no type of a question.
Right. That's correct.
Yeah.
Yeah.
So
Okay.
how, and for the same reason, the next we chose was what was it? We kind of disagree on
That's
that.
okay. That's okay.
So I chose what, Heba chose to. I chose what for again the same reason, more open ended, and I think I did not want to go with do because again it's like mostly close ended, yes or no type.
Mhm.
Heba might have a different reasoning for choosing to. Um, this next one that I chose was why and then do. And again, it's because of the same reason, more open-ended. It will allow them to think, right? It's hard to know which one would be the more,
Yeah. Okay.
the best one.
All right. Well. No. She asked, do you want to defend yourself? And she says, no. Okay. So somebody else, would you like at least one more here with somebody want to offer? There you go. Right there. You can say, but
Um, Hello.
Hello.
Uh, I think it just depends on the questions because
Uh-huh.
you can really make any of them open-ended. Like, like, do you ever think of how alcohol plays a role with your family or things like that? Why was the only one where I was like, because I kept using it as why do you drink or why do you do this? And it sounded a little accusatory.
Mhm.
So that was the only hesitation I had with that particular question. But you could probably use it in a way that wasn't. So.
Okay. How about one more? Just give it to somebody. That's not eating. Yeah. I think you should give it to Dr. Menz. I'd love to hear. I would love to hear.
I
your
like
input.
my job.
You like, oh, well, I like mine too, but I think he would answer okay. Yep.
We picked why and we kind of simulate with the question. We start out with why. I personally like how and what. But
Okay.
as Charlie said, we can put it in a way that why not kind of becoming accusatory or like asking for the requiring answer or the reason. Yep. So, and the two would be the close-ended questions, so we put at last.
Okay.
you.
Well, thank you very much. You see, we're not all the same and it's okay. If you were to probably ask me, I actually will put what at the top of the list. And I'm going to show you some questions with the what word and why I think it is. Now, why is okay. That one's a tricky one. And I think you got the reason right there because it can be accusatory. It all depends on how it comes out of your mouth. Why did you do that? It's not, yeah. So you got to be a little bit careful with why. It's a good question, but be careful with it and how you say it. The do word, I would put at the bottom because typically it's going to be a yes or no, just about always. But do you know what? That is the word we probably use the most is do you. I don't, it just does. For some reason, we've all learned that somewhere along the line. So what? And I'm going to give you some examples of here how you might think about that what question. One of the things about if you're asking what, and then you do a little silence after you've asked your question, they have to answer because you've just given them that kind of a question. So I'm going to come back to that. Hang on to it for a little bit. So here's some things to do. You want those open. Everybody mentioned the open-ended questions. Yeah, you want those things. So that's where you get the tell me about. What are you thinking? What are the barriers? Those are the kind of things to do. So you can look at the pros and the cons, we can talk about both of those, positive and negatives. What worked before? There's the what word. What happens if you continue? There's the what word. I like change rulers on a scale of 10 to 10. How important is you to stop using drugs or how confident is it you think you can do this? And what I like with that one, if they say, 5, and you can say, well, what made you say, why'd you say 5? What made you say that as opposed to a 2 or 3? And then you can have conversation about that of, why aren't you over here instead of over here? And then sometimes just coming alongside with them and just affirming where they are. It's not that you're agreeing with them, you're just affirming where they are. Other words, I want to check in. I'd be interested in, be curious, always be curious. I'm always curious about what you say. Sometimes just making the statement, it's really hard for you to talk about this. I like the term one interpretation is, and if you use that one, you might want to flip it around and say, oh, or another interpretation is. It's good because you want to put that out there and let them think about things. And honestly, I am concerned is one of the best things you can say. There's actually studies out there that say that providers, if you're using the terms and sincerely meaning, I am concerned, people listen. I had that happen to me. He's one of my physicians, but he's also a friend and colleague. And it wasn't about opioid use at all. But it was about something else, a medication he had prescribed for me. And then something else happened, and it might have been a side effect of that drug. And I remember him sitting there just very thoughtfully, and he said, I'm really concerned. He said, I don't think it's that drug, but I'm very concerned. Boy, it got my attention. It really is. It just makes you really think. So I am concerned about. What are the barriers to? Okay. What keeps you from? Tell me about. And sometimes you want to say, I'm just going to check in with you. It sounds like this. You're going to check in and see if you're hearing them what you think. Sometimes summarizing, kind of helping them pull it together. Here's what I'm hearing. These are all motivational interviewing type of language. What's not there in motivational interviewing is the do you. I just call them do you sentences. Do you this, do you that, do you this. And also, can you tell me? And for some reason, we are somehow subconsciously trained to do that. Sometime back, I was just a regular doctor's appointment, and the MA was, we were in the room, and she was asking me all these questions, and she just kept going, can you tell me? Can you tell me this? Can you tell me that? And I was like, this is driving me crazy. And so I finally just said, yes. And then I felt really bad. They totally flustered her, but I said, don't leave the can you off of there. Because yes, I can, or no, I can't. So it's really hard. And you have to train yourself not to do that. And then the you shoulds and the you need tos. Just may not be the right time to use them. So you have to try to train yourself. I still work at that, is not to do that. Well, there are some barriers to motivational interviewing. It gets sometimes the implementation of patient-centered care, how we do our care, gets in the way of motivational interviewing and really helping patients connect and get to where they need to go. And honestly, I could make a whole session and talk to you and have a great discussion about what is your definition of patient-centered healthcare. I would love to have that sometime. But we can't provide it if we continue with some of our provider-centered communication language that we've just learned along the way, or it's just our habits. We like to go talk about the patients outside the room. Well, we have that visit with them. But if you want to talk to your colleagues, you want to do it outside the room. There might be a time when that's important, but for the most part, why are we doing that? Going on autopilot and using our trained everyday professional talk, we get into this thing of just, this is the way we talk to people. And not listening for how do they make sense of their situation is real important. And that takes me back to my theory of planned behavior and kind of understanding where they're coming from and how are they making sense of it. There's a common problems we run into. You think I need to tell my patients what to do. A friend of mine who's a nurse practitioner, she's now retired, but she worked in cardiology, but she says, no, I tell them what they need to do. And if they don't, well, they don't. I thought, ooh, you're losing people. But anyway, will do what makes sense to them. They will make their own choices. Another quick dad story, and it has nothing to do with opioid disorders use, but my father had congestive heart failure, in and out of the hospital with that. And one of those times that he was going home, they actually gave him a prescription for digoxin. Well, sometime later when I was at home with him and going through his meds, and I said, Dad, are you taking this? And he said, no. He said, I'm not taking that. He said, I take too many pills the way it is. And I said, oh. He said, well, Dad, here's why they gave you this one. All that fluid you have on your lungs that's making it really hard for you to breathe. I said, they're doing this to help regulate your heart. And if your heart beats better, it's going to help push that fluid out of the lungs. So I tried to connect it to what was really bothering him. And he said, oh. So he went back to his doctor and he told him that his daughter chewed him out. And I said, Dad, I didn't chew you out. But anyway, he did take his drug. So they will do what makes sense to them. I don't know whatever happened. Did nobody explain what the drug did to it? Was it in language he didn't understand? Or did he just totally miss it? I don't know. It was on discharge. So who knows? But they will make their own choices and they will do this. So you got to explore a little bit what's making sense to them. I just need to educate my patients. So back to my nursing students, when I was doing this research thing and talking about theory, I said, so students, I said, tell me, have you been taught, their second semester, I said, have you been taught about the risk of smoking? And I got eye rolls and all that kind of stuff that, oh yeah, ad nauseum. Well, this, at one time and here too, you could smoke inside. And then we went through this period. No, you can't smoke in the building, but you could smoke outside the building. Of course, then we had to walk through all the haze, and now it's no smoking on campus. But I was talking to them about that time and I said, that's interesting to me. I said, I see a lot of people smoking outside Albert Hall, which was one where all the health profession students was. Is that okay? And I said, so when you have a patient who smokes, I said, what do you do? And like in chorus, they all said, educate them. And I said, really? You all just told me that you've all been educated. And I know there's some people in here and smoke. I'm not going to ask you who they are, but I've walked through that smoke outside. It got their attention. It's like, education is good, but there's some things that they already know. They know stuff that's bad for them. This thing about empowering. Now, one of the things back earlier said motivational interviewing was about empowering, but you can also take that another way because that means giving authority to, no, patients already have power. You know, they have it. And it is my job to motivate patients. No, it's not. You probably can't do it. It's their motivations that have to make the change. So you're there to be caring and to be a resource to them. I need to fix my patients. That's hard as health professionals because we want to. It doesn't always work. I do disease management. No, you don't. They do. They're going to manage just like my dad did with taking his med. My patients lie to me, probably, and this actually there's studies that show that patients do, but they do it because of what's here, because they think they're going to be judged or treated as if they're stupid. There are real studies that show that. I'm wrestling. Well, yeah, probably pushing a little bit too hard on the needs and the shoulds. I'm the expert. You are. You are an expert, but guess who's expert on patient there? So that's where we're going to think. So positive things to do is develop rapport. And so get to know something about them. And it doesn't take a whole lot to get to know a little bit about their lives. I'm going to tell a little med student story here. I don't think it was any of you. I'm sure it wasn't, but I know it wasn't. But there was an event, there was something I went to as a session with medical students, and we hadn't started yet, and I walked into the room because I was going to be part of this, and I heard one of them, they were talking about, do we need all this stuff to get into med school and all that kind of thing? And could we shorten the time down and what might relate to that? But I heard one of them say, yeah, no, I didn't need theater. Why did I have to take theater? And I'm over there thinking, oh, you needed theater. You needed that class because all that little stuff that you take that's a little bit extra and you have a little bit of that in your brain, that can help you a lot with rapport. So I think it is important to broaden ourselves a little bit and just think about all the things we know something about that we can help establish a little bit of rapport with the patient. And never do the I understand how you feel. I think you know that one. It's not a good one to do. So try to reframe things, you know. I know I should quit, da 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 da. You know this can cause serious health problems. So just put it in a little bit different language in the way that you might want to do that. So always ask permission if you're going to provide individual. I know you do that. Respect their autonomy. Motivational interviewing has a lot to do with autonomy. You know, may I tell you my concerns? I am concerned about is good. Things just have to make sense to them. Ask them their thoughts and always summarize. That's what motivational interviewing is really about. So it's a collaborative approach. It's the with is the word that's essential here. It's evocative, meaning you're trying to activate their motivations. Honors their patient autonomy, give the work back to them, but they're going to be the ultimate decision makers about what they do. It takes practice. I'd work at this. And I took courses in how to do this stuff. So it's the tell me about what keeps you from. Allow time for them to respond a little bit and think team, expert to expert, that they are experts on themselves. And I'm going to, this is my last slide, but then we're going to do a little bit of a role play here. I love this picture. We have in the simulation center for some years now, we've been doing a scenario and we wanted to figure out one that would work well to bring different kinds of professions together. And so we do this one and it's about a homeless veteran is our patient. And he is an alcoholic and they meet him as a team in this scenario work that they do. But I love the look on this student's face because I think that she has the spirit of motivational interviewing. I don't remember how well she was doing motivational interviewing, and that's not something we specifically teach during this thing, but I love it. It's about the right heart set. And because it's the way you are with patients is more important than what you actually say. And Dr. Abel is handing out a little handout here. And then she and I are going to attempt a little role play here. And to set this up, we're going to be in a primary care clinic. Yeah, we'll go over here. A primary care clinic. And I am the nurse practitioner in this clinic. And I haven't seen her for a little while, and you'll hear the story of what's going on. She did have an accident about 6 months ago and she broke her collarbone. So we're going to hear about this in a little bit and follow along and you're fine to critique me. I don't care. Do they have, if they have the handout? Okay, they have the handout. Follow along on the little handout, and particularly in the middle part there, look for the different pieces of motivational interviewing. And we'll have a little discussion about that afterwards.
We'd like to have a part of the discussion is to help us figure out how could this be done better.
Yeah, we're working. Okay. Well, hello, Elizabeth. How are you? Hi, haven't seen you for a while.
Yeah, I know. I'm
Yeah.
sorry.
Oh, it's okay.
Things have just been crazy busy,
Yeah.
but I think I'm really glad that you were able to see me today.
Yeah, we could get you in a little bit quicker. That way I had some
Yeah,
time today
thank
and
you.
that was good. So I'm really glad you're here. I hear you're needing some more oxycodone is what that's what the nurse told me that you were wanting. Is
I
that?
am. I am. I've been in so much pain.
Yeah.
I broke my collarbone.
Yeah, that was about 6 months ago.
It was.
Yeah. Tell me your story. What's happened? Because I haven't seen you since that time.
I've been dealing with it, and I have been in so much pain. And in the beginning, I felt like I was on top of it,
Mhm.
and it just seems like it's not going away. And after 6 months, you'd think that it would be going away, and it's not.
Okay. So just to kind of give me an idea on a scale of 1 to 10, 10 being the very severe pain and 1 being none at all, where would you describe
Oh,
your
it's an
pain?
8.
Oh, an 8.
Yes,
Sounds like you're really in a lot of pain
I am.
along the way. So tell me about this pain a little bit more. When do you have more of it? Describe it a little more how this is going.
Yeah, I feel it mostly. So it's in my left shoulder. I broke my clavicle
Okay,
here.
and what were you doing to
I
get?
was on a bike ride.
Ah, okay.
Yeah.
All right. Okay.
So, and yeah, outside,
Yeah.
and flipped over my
Mhm.
handlebars, and I had my helmet on, but I broke my clavicle,
Right.
and ever since then, my shoulder has been hurting. So I don't know if there's something else that's going on, why, but I'm in pain all of the time.
Okay. So you had this done and then did you go back for a follow-up appointment with your orthopedic
I
surgeon?
did. I
or-
had an appointment. So I had the surgery,
Mhm.
and then I went back 2 weeks after, and
Okay.
she said everything looked great.
But you had a prescription for pain pills?
I did, exactly. And
Right.
so I was able to stay on that, and that has been really helpful.
Uh-huh.
I honestly don't know what I would have done without them.
Okay. So how often are you taking them?
I think it's every 6 hours.
And you pretty much just take them regularly? Have you done that?
Yeah, it's the 7.5 milligram
Yeah. Okay.
and oxycodone, and I if I usually know before my alarm goes off,
Yeah.
but I make sure that I take it every 6 hours because I don't want to get behind the pain. I want to stay on top of it.
Okay. What else have you done to help with the pain?
I'd done physical therapy,
Oh.
and I did that for probably a couple of weeks.
Uh-huh.
I stopped going because it was really painful, actually.
Okay.
So I didn't. Why would I continue doing that?
Okay.
I've been icing it
Uh-huh.
and ice and heat, and that seems like a waste of time,
Okay.
to be honest. And then I've done. I don't know if you know what CBD is,
Mhm,
but
I do.
I use CBD oil,
Yeah.
and that doesn't really seem to work.
Okay.
But I feel like I'm just doing all of this stuff, and it just is the pain is still there. So I
Yes.
think something is still wrong, and I feel like I need some more medication.
Okay, you want more Medicaid. Tell me, what else? Is there anything else you've been doing? What else would you be doing to help with this?
Um, I think probably those are the big things that I think that's pretty much what I've been doing.
Okay. Um, I'm concerned that it's been 6 months and you're still in this much pain. Um, Tell me, if I could wave a magic wand and the pain was gone, what would your life look like? What would you be doing?
Oh my gosh, it would
Yeah.
be so different. I would love to be able to do that
Yes.
without being in so much pain. I'd love to be able to bike again. I'd love to be able to play volleyball with my team again.
Mhm.
I want to be able to do things again. And I can't do any of this.
So it sounds like this pain is really interfering with the things that you would like to do.
Exactly.
Okay. I just share my concerns. 6 months is quite a long time to be on oxycodone and to be taking it very regularly. Concerns about dependence and even needing more. And if you go down the road, then you get into all kinds of other effects from them. So that's concerning to me. Okay.
I will tell you, I do not want to be addicted. I am
Okay.
so scared of that.
Okay.
And so but I'm in so much pain. You know, if I were
Yeah.
making this up, that would be one thing, but this is real.
Okay. So what if we make a different kind of plan, and let's kind of make a plan for getting you eventually off, but getting you some pain relief and figuring out what's going on? Would you like to talk about that?
I'm open to that. I
Good,
mean,
good.
if I can be off of it and not in
Yeah,
pain.
absolutely.
Yeah.
That would be our ultimate goal. Would be
Okay.
down the road, and you can be back doing all those active things you do.
Game
I
on.
certainly don't play volleyball, but I'm glad you do. That sounds like a lot of fun. So I think there are things we can do. There's some guidelines about how to get off of an opioid, and we can look at. I'll write those down for you, and
Okay.
we'll use some other things instead, like some Tylenol, some ibuprofen, and what have you. I think there might be some advantage in going back to your orthopedic surgeon and doing a reevaluation of, because it should be healed better
Okay.
than this by now.
Okay.
And I can get that set up for you too. And the other thing, physical therapy. I was wondering if you would like to think about going back to a physical therapist.
I mean, I can, but I don't want to go back to the same place. I felt like they didn't know what they were doing.
Okay, there's others. And sometimes you just, well, and I'm not going to criticize, they may be very good physical therapists, but sometimes we just don't click,
Yeah,
with
yeah.
what they are.
Yeah.
So we could try another one.
Yeah,
Okay.
I'm open to that, but I'm not going to do that without my meds. Like, right?
Mhm.
I need to make sure
Oh, we're
that.
going to make sure you're comfortable
Okay.
and get something along the way.
Okay.
Okay. Good. I'm glad. I think we should do this. That
Okay,
from
yeah,
my
I'm
perspective.
open.
Okay. So I'm going to ask you one more question here, and then we'll kind of write things down and get
Okay.
things started. On a scale of 1 to 10, if 10 was very confident and 1 was, I don't know if I can do this and get off of that drug because it makes me feel better. Where would you be on that confidence scale? I'm confident that I can do this. Where would you be?
I'd say probably a 6. I mean, it sounds like you can walk me through this and that you can help me through this. I really do not want to be addicted to anything.
Okay.
And
That's
at the
good.
same time, I really don't want to be in this kind of pain.
That's right. You don't. So you said 6. What made you say 6 as opposed to a 3 or 4?
I guess, I mean, because I don't want to be addicted, I have that feeling that I'm motivated, but
Mhm.
I also, I mean, I think you're kind of telling me that this can be done and you know how to make it happen. So I'm
Okay.
willing to give it a shot.
Good. You're a strong woman. I'm sensing some resilience there that will help along the way. So we will get things set up, and I'm going to write some things out for you, and we'll also get some of those appointments set up and kind of take a track. I want to check in with you next week.
Okay.
Okay. And we might even just set an appointment time so that we're both available and can talk for a little bit
Okay.
and see where we are.
Great. Thank
Thank
you.
you very much for coming in.
Thank you. How could we have done this better? Not my acting, obviously. That was your hair. He has moved his hair.
So you might look in the middle of your sheet, and did I hit some of those things that are in the middle? You are free to critique me all you want. Here, got a hand up.
I guess one thing I could say was that although there was certainly time devoted to letting the patient explain her story, it sort of started off with this is what I heard that you want, rather than letting them open up and just sort of asking a
Mhm,
more open-ended question at the start to let them present what they were coming in for to you.
Okay, yeah, absolutely. How would you ask that question?
I'd probably ask something along the lines of after you were saying about how it had been a while. So what brings you in after all this time?
All this time. Okay, yeah. And that was a what question? Yeah, that's great. Did I do anything okay? I might ask you that question. Okay. Yeah, because it's not just what did I do wrong? Also, what worked here? Yeah, okay.
Yeah, I mean, I think pain management is always difficult. But I think I guess I would like to have seen more of the empathetic statements, recognizing that it might be hard
Yeah,
to
absolutely.
live with that amount of pain.
Yeah,
Uh,
absolutely.
I think,
Yeah, that would be really helpful, I think, for her to hear. I think it would.
right.
Yeah, you seem like you're in a lot of pain.
As far as what went well, I think that there was the clear MI spirit there. There's a lot of collaboration, especially at the end, evoking the patient's beliefs about how they could get better with all the assistance that you were offering. And I think there was also some good reflections made.
Okay, thank you.
I liked very much about the evoking the change, asking about what their ambivalence is. So look like the patient is having pain on one hand and not wanting to be addicted on the other hand, and not wanting to be addicted to have that peace, and also giving the information what they can do about that. So that really I liked it, and then another thing, the question that I like is on the scale thing and also what makes it 6 in opposed to 2 to 3.
Yeah,
I really liked it.
I like that one too.
Yeah, and then the collaboration of like making the plan together.
Mhm.
So yep,
Yeah,
thank you.
Now, I will say she was a pretty easy patient, don't you think? Yeah, they're not all, and we were kind of purposeful in that because we didn't want to get down in the weeds of some of the clinical cases that go on, but yeah, comment over here.
I really enjoyed how you kind of brought it back to her interests and everything. Because if you're just like, hey, we can get you off these meds, keep you out of pain, that's one thing. But getting her back to the life that she is used to and she wants to be, I think that's even more like gives them more of that determination factor, and that you're both working to get them back to that position. So like just being out of pain is great, but being out of pain and being back to doing all these things that's awesome.
Playing volleyball, huh? Yeah. Okay. I'm curious, you can comment some more. I'm curious about, have you had patients that you've dealt with that you tried some of this and it worked or it didn't work, or, questions about things you might want to do?
I guess I can comment a little bit on the concept of it not working. And
Okay.
you sort of brought this up, you've got a person that has a good personality structure, and in a group of psychiatrists, I think when you're going to get into some problems is when you have somebody who doesn't have quite as mature of a personality. Then you start getting blistered with sort of projection,
Absolutely.
immature defense mechanisms,
Right.
all those sorts of
Because you
things.
have all that other stuff to deal
That's
with.
that's
Yeah.
probably something you're more likely to see in certain psychiatric environments rather than sort of a general population.
Yeah, and that's why I think this tends to always come back to it's those who are ambivalent about stuff, I could do that, I need to, but, and that's where motivational interviewing just kind of has some of its strong points too. He's done his part, yeah. Yeah, he's done his part, yeah.
I think whenever I start with our PGY3 residents, I always indicate that I take the position that we are advisors.
It's a good one.
We're their consultants. And it, after all, is their life,
It is.
not our life, and how they choose. Now, there are occasions where society intervenes and where they're going to do something that is of imminent danger to themselves or others. And then under that situation, we can't just let them do what they
No.
want to do. We have to involve a judge. But in general, sometimes you get into a situation where what they want to do and what you think is not medically appropriate are divergent. Well, you don't have to get upset with the individual. You just say, that I can't participate in this portion of your care or your care because we are fundamentally at odds with each other.
And it's just not safe for you to do that. So,
I'm
and
sorry?
it's just not safe for you to do whatever it is you're talking about. Absolutely. Are we running out of time? Oh. Well, thank you very much for being a very attentive audience, and this is just kind of fun. I love this part about it being the heart set. I will ask one last thing. When I kind of started working with this a little bit more and I needed some practice, I will tell you, don't practice on your spouse. It doesn't really work really well. Because I kind of did that, and I was pushing on something, and he finally looked at me and he said, "Oh, you're doing that thing you do." So I don't recommend working with spouses. It doesn't work real well. So thank you very much for listening today. Thank you.
Very, same here. Make sure this is.